Belki, Assistant Director General for Antimicrobial Resistance, and Dr. Sylvie Bree, Preparedness. I'm also pleased that today we're joined by Peter Sams, Executive Director of the Global Fund, and Dr. Ima Hanai, Chief Access Officer of FINE. And welcome to both of you. Welcome, Peter and Ima. As always,
speech in the chat box, and also the speech will be posted online as always. And we do apologise if some colleagues did miss the first 30 seconds of this afternoon session. With that, I'd like to give the floor to Dr. Mike Ryan to introduce the technical and epidemiological update, an update on COVID-19 clinical operations. Over to you, Mike.
Thank you, Tim. And just very briefly, to thank all of our partners out there on the science, operations and logistics side who worked with us since day one to deal with the huge issues that occurred last year with supply chains, but not only with supply chains, with the definition of materials, particularly in the biomedical space, which are not just a procurement issue. There's an issue of identification, validation, adaptation, training, as well as procurement, distribution and supply. That's required a very, very successful interaction between clinical and medical services and logistics and procurement services all over the world. We're no different here. Our operations support and logistics team have worked very, very closely with Guillaume and Paul Marinaro, and with our regional colleagues, and particularly with our regional supply hub in Dubai. Work very closely with Janet and her clinical team, and by extension with the Biomedical Consortium, which is a partnership of experts from around the world who worked very closely with Janet, Guillaume and their teams on this issue, but also in the broader front with our colleagues and partners within the ACT Accelerator on the Emergency O2 Task Force. So this whole area has required new relationships, new engagements, new innovation, new research, new distribution means, and solving many, many problems as they were confronted in real time. And I must say, I'm deeply grateful and proud of the efforts that have been made by people from multiple professions and multiple sectors to try and come together and solve these problems. But they're not completely solved. There are still significant issues in terms of the supply of oxygen, PPE and other materials, and still some significant challenges, as Janet will outline, in clinical management, clinical care, clinical triage. There is no point having commodities that can save lives unless you have the health systems, the doctors, the nurses, the management pathways, and the quality of care needed to deliver those interventions safely and with a successful patient outcome. So with huge thanks and respect to the work that both these groups and all of our partners have done, I'll hand over to Janet and Guillaume.
Thanks so much, Mike, and thank you, DG. It is my pleasure to present on behalf of the team behind us that is doing all this hard work. I'm going to be presenting on the update of clinical operations for COVID-19 therapeutics and oxygen. And next slide, please. As you're all aware from your own experiences in your own countries and also through the media, that once the epidemiological curve starts to go up, and especially when it starts to go up steep, that the systems can become quickly overwhelmed. And we've seen that time and time again. Prevention remains the key to stopping transmission. For the rest of the talk, though, I will talk on clinical operations because we must care for those patients that do get infected and do the best care possible for them. Next slide. We are supporting a comprehensive, multidisciplinary, holistic approach for caring for patients with COVID-19, from triage to recovery. This includes 6 domains that must be addressed simultaneously in order to provide that quality care. It includes staff are multidisciplinary, trained, that they're kept safe, and that the staff is not just in the hospital, but it's in the community and the primary care services and in the tertiary care facilities. Structures must be built, must be reorganized or refurbished or rethought to improve patient flow, that there is adequate ventilation, and that IPC engineering and administrative controls are present. Supplies must be made sufficient. Supply chains where you don't run out of life-saving equipment, such as biomedical equipment, medicines, life-saving medicines, and other therapeutics when they become available. Systems be put into place that you can take care of patients in their home, if that is the national decision, in the community facilities, if that is the approach, and that referral pathways are in place to get patients that get sick to the right place for care, where there is a hospital, where there's an intensive care unit. Studies that performing and conducting clinical trials or clinical studies to look at clinical characterization is important to understand what is the disease looking like in my country. And if I have a variant of concern, what is the disease looking like? Is it changing? And then clinical trials, if you're able to participate in those large-scale platform trials to contribute to the evidence base to generate guidelines. And then standards. Can we implement the norms and standards as they are quickly evolving into clinical practice? Next slide. Here, hopefully you are aware of the 3 major guidelines for clinical care. One is focused on therapeutics in COVID-19. The second is on the comprehensive clinical management of patients with COVID-19. And the third on drugs to prevent COVID-19. We have an innovative approach to doing living guidelines that tries as best as possible to stay up to date with a publication platform that's also electronic that can be found on the Magic app website, as well as a publication on therapeutics that comes out with infographics in the BMJ. Next slide. Most recently, we did publish 2 clinical care bundles. Bundles are evidence-based interventions that, when done together, improve outcomes. Here is one for home care that you can see on the left. And this one focuses as well, not just on interventions, but we must think holistically, such as psychosocial care interventions, in addition to the medical interventions, such as using a pulse oximeter at home in order to detect early signs of clinical deterioration and appropriate timing of referrals. The second is the clinical care bundle for the health facility, and here it is the use of oxygen if the patient has low saturation, the use of dexamethasone if it's for reduction of mortality in patients with severe and critical disease, and the use of thromboprophylaxis to prevent thrombosis in patients who don't have an indication for higher doses. And these are our bundles. Next slide. As you can see here, we're going to be updating the living guidelines in August 2021. We will soon have new recommendations on MISC. That GDG, that's a guideline development group, will meet on the 24th of June. We will also update our guidelines on non-invasive ventilation and high-flow nasal oxygen for severe and critical COVID-19, also towards the middle and end of July. Right now, we do have a recommendation for their use, though, for some cases of critical COVID-19, and that its use should be done with caution. We have new systematic reviews that are ongoing, looking at co-infections such as mucormycosis, thanks to colleagues around the world. And the main message here that I do want to share is better diagnosis and management of diabetes. We need to avoid hyperglycemia and use the rational use of corticosteroids, meaning low dose, short course, and reserved for those with severe and critical disease where it is life-saving. We will also be updating on pregnancy and COVID-19, children in COVID, and HIV in COVID. Next slide. The therapeutic guideline is actually soon to update on the 30th of June. And here I would like to share with you a draft recommendation that will be published towards the end of this month. And this will be a strong recommendation for IL-6 receptor blockers, tocilizumab and sarilumab for severe and critical COVID-19. This will be used and recommended on top of corticosteroids that are being used already as the standard of care. In pipeline for the GDG, the Guideline Development Group, for June and July, we will be reviewing the rapidly emerging evidence. A press release is, I think, just released yesterday on Regeneron CoV-2, monoclonal antibody. We'll also be looking at baricitinib, full-dose anticoagulation, and convalescent plasma, of which the data continues to emerge in more and more numbers. We are monitoring studies for some of the earlier pipeline drugs, such as molnupiravir, GSK monoclonal antibodies, And once there's enough evidence to take that to GDG, we'll be writing recommendations likely in Q3. Next slide. But let's move on to oxygen. We have launched our Oxygen Access Initiative. That website is, you can access that website. And on there is trying to put together all the important information on how to approach oxygen scale up at country level. As well, next slide. You can point 3 times. There you go. On that website, you can find 3 important safety posters, and I wanted just to flag these. These are posters on safe use of oxygen cylinders, how to mitigate fire risk, because we've also been unfortunately seeing that risk, and how to just ensure safe use of oxygen. Next slide. I want to take this opportunity to alert all member states that we are launching an O2-COV2 observational study, and this is a respiratory research study. What we're trying to assess is the patient-level use of oxygen and respiratory support devices in low, middle-income countries to understand really per patient what are the practices being used and how can we use that information to better make our estimates for what our oxygen needs are for COVID-19, as well as improve care practices. The EOIs are, you can actually see the expressions of interest forms available online, and we'll be taking submissions until the 9th of July from research facilities that are interested, so please share with your research colleagues. Next slide. But going on to the practicalities of oxygen access scale-up, we know the challenges that exist, and we know with each peak, when the peak goes too high, the systems can run out of oxygen. So the important thing is to be ready. But what are your need gaps? And this has to be done at the country level. And you have to find out with a careful needs assessment, is it an oxygen source? Is it that you need more liquid, another PSA plant, more cylinders? Is it a distribution system problem or transportation problem? Is it the delivery equipment? Nasal cannulas, nasal prongs, consumables, spare parts, training, maintenance, service agreements, power generation, funding. These are all the potential gaps that you may find in your countries, and these need to be assessed and then make a plan on how you're going to fill those gaps. What we would recommend now is a very coordinated approach with multidisciplinary expertise. We've used our model here with biomedical engineers and technicians, with OSL, logistics procurement specialists, and with clinical teams working together to forecast needs, to do need gap assessments, to develop contextualized solutions, and then proceed with procurement, installation, and commissioning. This has to be done at the country level, working with partners, and trying to optimize everyone's best talents to make this happen. So what is your search plan? These are the questions I ask you. Does your search plan include liquid, bulk? Does it include more PSA procurements? We've developed a standardized RFP to help us support our regional offices and country offices do procurements for PSAs. Is it that you have PSAs in countries that need repair and maintenance? We also just launched an EOI for entities to do repairs and maintenance, and we've received 4 submissions already. And cylinders, is it that you need more cylinders, and so what are the local good quality cylinders in your area? Of course, that is in addition to all the technical documents that we have published on our website, which include technical specifications for medical devices, technical specifications for PSA plants, medical delivery devices, and also the tools to do forecasting, the ESFT, of which my colleague Guillaume will describe, as well as the inventory facility. So with that, I'm going to pass off to my good colleague in OSL, Guillaume. Over to you.
Thank you, Janet. Thank you, Mike. Thank you, DG. And thank you very much, all of you, for giving me the opportunity to present and give you a few data on the supply as it's going today. So here you see we've decided to focus on O2 concentrator, as we trust this is quite representative of what is going on today with the still a high demand on all the good medical equipment in order to increase the case management capacity in country. A lot of countries are still demanding quite a lot. So you see here the O2 demand for the past 2 weeks, which went from the number we delivered 39,000 O2 concentrator and to 49,000 delivered at the end of those 2 weeks. And in the meantime, the demand that went from 13,000 to 23,000. This is very much linked to India and Nepal, that are very much, that we're looking to increase their capacity recently to face the peak that they had too, but it also represents a general trend on that. Next slide, please. So this is the overall supply that was done on June. This is the issue from the beginning of the response, which reached nearly $68 million of supply for invasive and non-invasive therapy. But again, focusing on the O2 concentrator, just to show you here that WHO alone has pushed 20,000 units to the field and is now preparing to push another 8,000, which makes us the provider of 46% of the total O2 concentrator supplies. So the demand to the whole system, to our colleague from UNICEF, Global Fund, and the other partner supplying that is still quite high, and the demand on WHO is also quite important. I trust that this is also very much due to the unique capacity of WHO not only to supply, as Janet and Mike mentioned, we're working very closely with the medical team and the case management team in order to provide our member states with the end-to-end support. The expression of their needs and making sure that what we are going to push later with the system match what they need on the ground. Next slide, please. A few words on the market as it is today. So the O2 concentrator market is a bit special indeed because the demand was very high in those days, and it has seriously increased the lead time. So delivery of any acute situation today is difficult. There is a high demand on accessory and consumable as the whole system is running their case management system. But the rest of the items are kind of normal. Now, transport and logistics remain a very complex issue. As you know, the air traffic remains low, and so access to cargo space is difficult, and there was a shortage of sea container recently. The price of the transportation remained very high. It has been multiplied by between 2 and 4, depending on where we're moving our supply. So WHO continues to quite be an important actor in the global supply of biomedical items in particular, but also PPE and diagnostic. We were wanting to phase out of the routine supply in the response, but we're still facing quite a large number of demand, and especially when the countries, member states are facing acute situation. So the portal system that you know is still running, and we're still supporting any demand coming from partners. The catalog is being updated based on Janet Group's recommendation in order to better match the demand of the different member states. As Janet mentioned, we are still trying to improve our essential supply forecasting tools to help countries define their needs, but also for us to get a full understanding of what are the global needs, as we are also, and thanks to our partner for that, monitoring the whole supply that is being pushed to different countries from the different partners, and trying together to identify where there are gaps when there are some.
$1.2 billion worth of equipment that supplies to 176% of all of the international materials. So it became a vital mechanism to get essential supplies to countries. The difficulty we face right now is that WHO is faced with the reality of also not just being a first mover, but now being once again, a year and a half into the pandemic, a provider of last resort. WHO does not have the resources to do this. We have not received the resources to do this. And in fact, we have been greatly criticized by certain reviews that WHO shouldn't be operating in this space. I put it to you as our member states, somebody needs to be operating in this space because we're still filling gaps every single day. Gap after gap after gap in the global supply chain system, and countries are desperate to get access to materials. We no longer have the funding. I've laid it out to member states before. Of the funding we've received, only about $50 million of that funding is flexible enough to use for procurement for any given situation. 85% of the money we've actually received, which represents a quarter of all of we've asked for, is earmarked for particular countries or for particular areas of work. So it is very difficult. So we do need to be able to move forward to normalise, as Guillaume said, the supply chain in a way that countries can expect to receive from the international system a guaranteed supply based on their stated demand. Currently, this is not happening, and WHO is having to constantly fill gaps with resources we frankly do not have, and it's putting extreme pressure on our systems. We will continue to do that. That's our job, is to serve you, and to serve you where we can, to find the resources, to find the materials, and we have a highly professional group of individuals throughout our whole organisation who do that every day, in addition to the work that we do in other procurement areas. All of that works extremely well because of the way in which the supply and procurement is integrated with the quality assurance, with the validation, and with the training, and with the know-how that's needed at country level to use these interventions. That is the real connection that WHO can make. So with that a plea, I would ask that we ensure that other systems can fill in these huge gaps in supply right now, or that WHO be provided with the resources to fill those gaps. Because right now we have expectations, daily expectations on this organisation, which we simply cannot meet on the financial side. Thank you.
Thank you very much to Mike, Janet and Jian for those presentations and comments. I may now invite our moderator for today, Mr. Jude Ossai, Senior Protocol Officer in the Department of Governing Bodies, to moderate if there are any questions or comments for our first set of presenters. Following the questions, any questions and comments, we'll then go on with the second part of today's presentations, which is the update on the ACT Accelerator. So over to you, Jude. If there are member states, please raise your hands on the platform as per usual.
Thank you very much. I did not see any requests for the floor, but perhaps we just give ourselves a few more seconds, and if they are. It doesn't appear to be the case, Chair. Thank you.
Thank you, Jude, and thank you once again to our presenters from the first set of presentations this morning. Now we'll move on to an update on the ACT Accelerator, diagnostics for COVID-19, status, what's new, and where next. And first I'd like to hand the floor to Dr. Bruce Aylward. Bruce, you have the floor.
Thank you very much, Tim, and good day, Excellencies, attachés, and ministry colleagues. Further to the Director's introduction, as you've heard over the last couple of weeks, we've had extremely important and encouraging progress on the vaccine side of the ACT Accelerator. We now have a fully financed advanced market commitment for vaccines, as you know, as a result of the ANC Summit we spoke of last week. We also have increasing vaccine dose sharing and donations following the G7 announcements of last weekend, as you're aware as well. However, as you also heard from the Director General, we have an acute situation in terms of the scale-up, which will take time. That makes the importance of diagnostics, the ability to rapidly identify where this virus is circulating, that much more important in the near term. As you've seen in introductory comments, the virus is still surging in key areas of Africa, also in substantial areas of Southeast Asia, Latin America, and the Western Pacific. So the diagnostics, of course, as a number of you have highlighted, are absolutely crucial in understanding the impact of vaccines, rapidly identifying cases and guiding isolation, as well as, of course, ensuring appropriate treatments. So today we are delighted to be joined by the full diagnostics pillar representatives who have agreed to provide a detailed overview of the situation with respect to diagnostics and their scale-up. We will be doing a deep dive, just looking forward, on the 6th of July on a number of aspects relevant to the ACT Accelerator, and we'll be receiving an invitation to that in the near future. It will be co-hosted by our co-chairs of the ACT Accelerator, the Honourable Ministers of South Africa and Norway. I would like to remind that today's session, with the detailed look at diagnostics, is as a result of a direct request from you, the member states, and I would encourage you to continue to send questions and suggestions for updates as we go forward with these member state briefings. At the closure of this session, Tim will also be willing and able to take questions on any aspect of the ACT Accelerator. Something as Swaminathan, our chief scientist, to lead on the COVAX piece, as well as those who are online, should there be questions in those areas as well. So with that, I'd like to hand to Anand Balki, who is our Assistant Director General for AMR, as you know, but who is also the WHO lead on the diagnostics pillar within the ACT Accelerator. Anand.
Thank you very much, Bruce. Thank you, DG, and honourable ministers, distinguished delegates. It gives me great pleasure to start the ACT Accelerator Diagnostic Pillar session. And with that, we will go right ahead to our presentation, starting with Dr. Emma Hannay, Chief Access Officer from FIND. Emma, you have the floor.
Many thanks, Nana, and many thanks to all for giving us some time and space in your packed agenda today to talk about diagnostic testing for COVID. Diagnostic testing, as many have talked about, is really the eyes and ears of your COVID response in countries. And so we'll talk a little bit about what the state of the science is, what state of access to testing is, and also some of the initiatives that have been launched through the ACT Accelerator, including an update on where things are in Global Fund's C19 response mechanism. So what we wanted to do is just to start with an overview on the diagnostics that we have at hand for the COVID response and where we are in terms of the market for these products. There are two products that we've been tracking really closely through the ACT Accelerator. The first is PCR testing, so laboratory-based testing for COVID, as well as antigen rapid diagnostic tests, which can be deployed in more decentralizable settings. And so what we've seen since our last member state briefing with you is considerable evolution in these markets, particularly in terms of the price for some of these products, and that's what's highlighted here on the graph on the right-hand side. What you can see is that in both the PCR space and the antigen rapid space, we've seen a reduction in the ex-works price paid via the supply consortium for these products, which is really the result of a series of collective actions that have been taken by a number of groups involved in the ACT Accelerator partnership. And that's included investments in R&D to bring new manufacturers onto line and through the WHO EUL process, take advantage of some of the increased efficiency for scaling of manufacturing of rapid tests, as well as local manufacturing. As well as that, obviously, there's the coordination that happens via the UN Supply Consortium for the procurement of these tests, allowing a number of the major procurers from the global health space to work collectively. And in addition, there's the guidance that comes out about the use of these tests, and we'll talk a little bit later about how this guidance is going to evolve over the coming weeks, which will be an area that the WHO team will add a little bit more detail on soon. In addition to price, although obviously that's a really important measure for us, there are other characteristics that are really the focus of work upstream in the R&D side in the ACT Accelerator, and that includes to bring more easy-to-use versions of some of these tests to market. So to be able to perhaps do these tests like a simple nasal swab as opposed to the more intrusive nasopharyngeal swab at the back of the throat, as well as ultimately through 2021 aiming to have self-tests available at a low price that are appropriate, particularly for low middle-income countries. If we jump onto the next slide, and I'll be relatively brief here, I've talked a little bit about how the Supply Consortium has played an important role in shaping that market. So to date, about 80 million tests have been procured via the Supply Consortium, both a mixture of PCR molecular tests as well as antigen rapid diagnostic tests through a large range of the major procurers who are a part of that consortium. And that includes a group of over a dozen different procurers who play a key role in helping to shape that market towards lower cost tests and higher quality tests, quality assured tests that we have available via the WHO emergency use listing process. But if we take a step back and have a look at where we are overall in terms of diagnostics access and jump onto the next slide, what we can see is that there is a growing gap between the testing rates that we see in high-income countries, which is that line at the top, and everywhere else, which is the lines at the bottom. Both low, middle, and upper middle-income countries are tracking at testing rates significantly lower than those we're seeing in high-income country rates. And actually the extent of this equity gap appears to be increasing. When we last briefed you in late 2020, as you can see, that gap was still there, but is it becoming even more apparent? And so what we are going to talk to you a little bit more about is where some of the perhaps different uses of these tests might be particularly relevant, and how we can expand the use of tests, as we've seen it in many high-income countries, to be able to meet the public health needs, the economic reopening needs, and other social needs that communities and individuals have. One of the particular risks that we see in some of the low testing rates in key countries is that countries are using measures like hospital occupancy to measure how severe their COVID wave is. And by the time hospitals fill, it's simply too late. So testing is really the best way that we have to be able to track what's happening in real time in a country's COVID response, and to be able to support them in responding to it. And with that, I'm going to hand back over to Hannah.
Thank you very much, Emma. So I think for this next slide, what Emma emphasized and what all of the member states have been doing a great job in trying to incorporate diagnostics into their COVID strategic guidelines and policy development at the country level. It's extremely important that everybody realizes that diagnostics is very different than vaccines, and the evolution and the continued management of the diagnostic space is not as attractive to donors, and it's not also very attractive to talk about, and it's a bit more complex because it's not a one-time shot. And understanding that, I think we are, all of us together with our member states and our partners, going through a very steep learning curve about how to address the issue of diagnostics at country levels. And with that, you can see in the slide that I'm sharing in front of you, the different platforms where we're trying to expand the communication, collaboration between our member states, partners, and all of you, and even within the wider community. For example, forums to understand the needs to enable knowledge sharing and training through WHO Public Health Lab knowledge sharing webinars, country and regional roundtables, regional workshops for digital tools, and how to incorporate that into the national strategic plans for diagnosing COVID and managing COVID from the larger national perspective is extremely important and evolving. The role of the WHO in the emergency use listing and novel international standards, and also trying to create the platforms to expedite the processes of the EUL. For example, developing the first international standards for antigen tests, and also a lot of technical assistance to the member states on enhancing and expediting regulatory processes at the country level. Other examples, for example, practical support for capability building, again, training and technical assistance. I'll talk a little bit about the forecasting tool in another slide. And also guidance on evidence generation to support the decision making, which we will talk about also. And Peter will address a little bit more about the C19RM work that has been going on. The next slide, please. The next slide shows again some of the regional forums for understanding the country needs and enabling knowledge sharing, which is extremely crucial, especially in the diagnostic space, where a lot of diagnostic tools are out there, whether they are approved by regulatory bodies at national level and some at the WHO level. We continue to encourage our member states in providing implementation research to enable us to better incorporate such research results into developing our guidelines, and that will continue to take place over the next months, if not years, as we continue to deal with COVID or SARS-CoV-2. This slide shows you 3 platforms: the WHO Public Health Lab's knowledge sharing, which included to date over 182 countries and over 7,000 participants from the different regions. There's also the platform of ACTA Diagnostic and Country Regional Roundtable, which we are working together, of course, all 3 of us, FIND, Global Fund, and WHO, relevant to share important updates and to support the ACTA and what is ACTA offering to countries and how to access this support, because sometimes the work that the different agencies are doing and the role of ACTA is still not maybe clear to all. So we're trying to enhance those regional roundtable discussions and for collaborative and information sharing. And the last platform, ACTA A regional workshops on digital tools and matchmaking. The next slide, please. This is an updated slide. We presented this several times, either myself or my colleagues from the EML, which shows the amount of research and development going on in the diagnostic space, where we are aware of at least 200 pre-submission interests, with expression of interest across the 3 different modalities of diagnostics, including the nucleic acid, the antibodies, and the antigens. And you can see an expression of interest of 145 in total, distributed between the 3 modalities of diagnostics: 64 nucleic acid, 41 antibodies, and 40 antigen. And the slide also shows how many of these have already been EUL'd and how many have not been accepted yet. And there is discussions with the R&D space to help complete some of the dossiers if that was the region of rejection or not acceptance yet. So that continues to take place, and we're working collaboratively with the R&D space also to make sure that this takes the shortest amount of time possible. I think with that, I would like to go to my last slide. The next slide, please. This might have been presented to you before, but this is an extremely important slide which shows the essential supply forecasting tool and emphasizing version 4 of this specific tool, where the WHO is working with the governments to make sure that they actually, and partners of course, and stakeholders, in forecasting the necessary volume of personal protective equipment, diagnostic equipment, consumables, biomedical equipment, and essential drugs. But version 4 offers some critical updates, including new pharmaceutical modules, including corticosteroids, anticoagulants, and inclusion of antigen rapid diagnostic tests, and a new forecasting option using data from Imperial College, and a separate dashboard updated bi-weekly, sharing the aggregate forecast of the potential global demand over a 12-week period. This is extremely important because it allows the countries to understand a little bit more about what the future might be and how they can ensure that the supply chain is enabled. And we hope to be working further with our member states and partners to see how to best improve this platform so that it serves the purpose it was built for. With that, I would like to hand over to my colleague, Sylvie Briand, to talk a little bit about whole genome sequencing and our diagnostic guidelines. Over to you, Sylvie.
Many thanks, Anan, and thanks, DG and Mike. In fact, we have created a new working group, the Diagnostic Genomic Surveillance Working Group, which is co-led by WHO and the Rockefeller Foundation within the diagnostic pillar of the Act A. And the aim of creating this new working group was to really increase the genomic sequencing capacities, but also the surveillance, so that we can better control this pandemic. Because as you know, we have seen the emergence of variants, and currently we have 4 variants of concern, and we need this capacity to track the variants, monitor where they are, and knowing in which country they are dominant or if they are co-circulating variants. And this information is extremely important for us to define if public health interventions are still working. I'm thinking in particular for vaccines, but also therapeutics and obviously diagnostics. So this working group will work at 2 levels. First, with countries, and to see if we can increase rapidly the sequencing capacity, but also the bioinformatic analytics of the genomes. And of course, the situation is very variable in the world. In certain countries, we need to build completely this capacity. In other countries, we need to increase it. But in any case, we need to connect countries and making sure that we can share data. And so this is why we are developing a plan for this, identifying where are the gaps, so that we can fill those gaps very quickly in the near future, in the coming months, basically. Then we work also at global level because it's very important to have integrated bioinformatics data systems. Genetic sequence data is information, and we need bioinformatics to analyze this information, and there are different platforms to do so. So we need to make sure that those platforms can talk to each other, and so that we can have a global analysis of this information. We are also pushing for more innovation in this space. This technology is quite new, and applying it to surveillance is also quite new. So we are working to make sure that we have tools that enable us to achieve our objective of surveillance. And finally, also it's extremely important, as Emma mentioned it earlier, for any kind of diagnostic to ensure good market shaping, ensure that the costs are affordable, of course, and there is a good supply chain to make sure that the product can be delivered to all countries. Next, please. Thank you very much. So on this map, you see that there are different, as I said, different types of countries and capacity. The countries with stripes are the countries who have uploaded genetic information, genetic sequence data information on GISAID, which is one of the major global databases for this information. But there are some countries for which we don't know if they have any capacity in genetic sequence data, in yellow, and other countries in blue. You have a dark blue, countries with quite good capacity, and light blue, countries with less capacity for genetic sequencing. But this mapping of capacity doesn't tell the entire story, because what is important also is the timing by which you can have this information. Until recently, there was at least 10 days and sometimes many weeks to get information for a certain geographical context. And so this is obviously too slow for us to assess if the variant is spreading and where and how fast. Also, what is really important is to have representativeness because we need to know the proportion of viruses that have been mutated in a given geographic context. And to have this proportion, we need to have representative samples and representative genomic analysis coming from this country. So we are facing quite a number of challenges, but I think this is benefit of being a working group, because we have been able to work together and bring together all the partners that are interested in this particular subject, and so that we can collaborate better and achieve much more in a limited period of time. Next, please. So this is to update you on the antigen rapid diagnostic test, because apparently there's been some question about how to use those tests. So just to tell you that WHO has issued a guidance on this particular diagnostic test, and this is currently under revision. The previous guidance is still valid, but we are adding more information as the evidence is growing on this subject. And these rapid tests are quite interesting because first you have the results more rapidly than with PCR, but also they can be performed outside laboratories, and sometimes it's very useful. But still, you need to have people who are trained to carry out those tests. So that's why we have, together with FINE, developed a training package that enables countries to train more personnel so that they can use those tests more broadly. And then finally, those tests, whether they are rapid diagnostic tests, PCR tests, or serology, have to be part of a strategy at national level. And so the guidance on the implementation guide for those tests highlights the need to have this strategy and give tips for countries to develop their own strategy based on their own context and epidemiological transmission. And more recently, thanks to Maria's and team, FIND as well, some infographics have been developed so that you can have a quick review on how to implement those tests and how to do it safely as well. Thank you very much, Anne.
Thank you, Sylvie. Thank you very much. Now we go to the last section of our update to Mr. Peter Sands, Executive Director of Global Fund. Peter, you have the floor.
Thank you, Hannah. The COVID-19 response mechanism, or C19RM as it's known, as many of you will be aware, is the Global Fund's mechanism for providing support to Global Fund eligible countries for their COVID-19 response strategies. And last year we deployed about $1 billion through this and related mechanisms. Right now we are deploying at least a further $3.3 billion through this mechanism. It is not specific to diagnostics, that's the focus here of course. It's designed to support countries on all the non-vaccine elements of the COVID-19 responses, including diagnostics, therapeutics and oxygen, PPE, fixes to health systems, and also, crucially, mitigating the impact on HIV, TB, and malaria services. The mechanism has two components, a fast-track component, which is for COVID-19 commodities, including diagnostics, and a full funding request component, which can support an array of different types of intervention beyond just COVID-19 commodities. What you have on this slide is the very latest update as of yesterday as where we are on the process. We have awarded $550 million in this latest phase, and we have in total nearly $2 billion under review and decision-making processes, and are anticipating the remainder of this coming through over the course of the next 3 or 4 weeks. So many of the countries that I know are attending this session, you will either have already submitted requests or will have requests in hand. Of the $550 million that is currently being submitted, if we could go to the next slide. Diagnostics represents 24%, and that's $133 million. The majority of that so far is PCR testing as opposed to RDT testing. We would like to see the RDT testing being a more significant proportion of the total, and this has been to some extent affected by the issues around the guidance, which was originally issued in September 2020, so 9 months ago. And so the latest infographics and the revisions of guidance, I think, are very important to helping countries make best use of high-performing RDTs in the context of an overall testing and transmission containment strategy. Incidentally, I would also, the other point I would make is that the figures given earlier by Emma on purchases through the Diagnostics Consortium won't as yet include the sums you see here. Likewise, and just referring back to the earlier session before this one, the 155 million on oxygen-related support is obviously a much larger number and wasn't included in the number, the 67 million or so, that I think was used in that earlier presentation. The point about talking about C19RM is that at the moment it is the largest source of grant funding to low and middle income countries, external grant funding for the non-vaccine related elements of the COVID-19 response, and therefore is, for the point of view of scaling up testing, a significant source of support. But even with the in total 3.7 billion we're deploying through phase 2 of C19RM at the moment, we fall far short of what the ACTA investment case regards as being the minimum really required to support countries on expanding testing. We go to the next slide. Thus far, ACTA-DX has received support from donors to the tune of about $1 billion, and we're very appreciative of the support that we have got. However, the total requirement is obviously significantly more. The original, the adjusted investment case number for ACTA-DX was 9.7 billion. Take $1 billion off that, you've still got a funding gap of 8.7. Some of that will be met through the portion of the C19RM money currently being deployed for ACTA-DX, but it will by no means close that gap. We still have a very significant gap to fill. Indeed, the Global Fund has designed and structured C19RM in order to be able to put through $10 billion as opposed to the current 3.7, which is, again, consistent with the overall shape of the ACTA investment case. I think the fundamental point here, and this is not specific to C19RM, it's true whichever channel we use to deploy the support, is that if globally we want to reduce transmission quickly, we cannot just rely on vaccine deployment. That is a crucial and essential part of it, but it cannot be done fast enough to reduce transmission as fast as we need it to be done. We need the broader range of public health measures, and to be able to implement those, we need a scale-up of testing combining both antigen and PCR across many more countries. And this is particularly true given the challenges of the new variants we've seen. So I'll close that and hand back to you, Helen.
Thank you, Mr. Peter Sands, Executive Director, Global Fund, also to Dr. Hanan Balki, Dr. Emma Hannay, and Dr. Sylvie Briand for your presentations. Now an opportunity again for Member States. Any questions or comments you have for any of our presenters? I'd like to hand the floor back to Jude Ossai to moderate the Member State interventions. Over to you, Jude. Thank you.
Thank you very much, Chair. I'm still waiting for a few hands to go up, and then I'll be in a position to give them the floor. I won't share that. Okay, I recognize New Zealand. You have the floor, please.
Thanks very much, Jude, and to all of the presenters today. That was a very helpful session indeed, and shows that these regular roundtables are very beneficial for us as a member state to keep across the different work that's going on. It's a very simple question to Dr. Hanan Balki, please. In terms of the ACTA diagnostic country and regional roundtable discussions that you mentioned, wondering how those were advertised and further information you can give about how member states can engage through that. Thank you.
Thank you very much, New Zealand. Japan, you have the floor, please.
Thank you, presenters, for this very high quality and comprehensive presentations on diagnostics. And so I have one question about the antigen RDT issue. It seems that it's been a while since the previous version of guidance on antigen or RDT was published, and so I'd just like to know the reason why it takes some time for the I think the latest version guidance to be prepared. Is it partly attributed to the lack of evidence or any, I think, issues related to that? Thank you. I'm curious to know about it.
Thank you very much, Japan. And I invite Zambia. You have the floor, please.
Thank you, Chair. And also I join in thanking the WHO and all the presenters for this very informative discussion. I just want to share and re-emphasize what the DG said concerning the cases that are rising in Africa. And Zambia is one that has been affected very badly in the recent few weeks. We have seen an exponential rise in new cases. And as of today, the country has pronounced a partial lockdown because of the high numbers of cases that we are seeing. But relating to the availability of the testing, which is a very important tool, as Peter said, that it is important that we need to do the testing for us to respond adequately and positively. We really need to have the availability of these testing commodities, which we are lacking at the moment. Yes, we have the money, and but where the market from which to acquire these testing commodities is proving to be a challenge. And the other thing we would want to know is whether the WHO has guided for specific RDTs, tests that we need to focus on instead of counterfeit, or how we can identify counterfeit or substandard testing, substandard testing commodities. Because we are seeing in these high numbers of cases, when they go, some patients will go to the clinic, they do an RDT, it turns out to be negative, but the symptoms are pointing to the presence of a virus in the body. And when we do the PCR, it turns out to be positive. So can there be a guidance on which are specific recommended for emergency use listing by WHO for testing? Thank you very much.
Thank you very much, Zambia. I see no further requests for the floor. Chair, to you. Thank you.
Thank you very much for the valuable questions. I'll give the floor to Maria for the first round of answers on the guidance. Over to you, Maria.
Thank you so much, Hanan, and thank you very much for these very important questions that you have provided today, and always for your support of tackling COVID-19. With regards to the guidance, I'm sure you've heard us present several times around how guidance are developed and the interim emergency guidance that are developed. These are constantly under review, even if they have been issued. And the question is about the antigen-based guidance, which was first published in September 2020. Guidance is updated based on updated information that we have on test performance for antigen-based tests, the use cases in which these antigen-based tests are actually used in the field, the data that come from those studies that are underway that capture the performance, and how they are used towards public health goals. And as those studies become available, we use that information to update the guidance. We also have regular discussions with our international networks, which contain experts from your countries, which we're grateful for. And we have a number of countries that are carrying out implementation research for antigen-based guidance. Those studies are actually currently underway, and we're hoping to get more data from those. With regards, there's an update that's undergoing right now in terms of the antigen-based guidance. In the meantime, our laboratory teams, our clinical teams, our epi teams are also producing other guidance materials as well, some of which include the use of antigen-based testing. We have a national testing strategy guidance document that we're hoping to be able to issue hopefully next week, which is an update to a guidance that has been published previously. But it does take some time. I know there's a question about this particular one of when it was published in September and why is it taking so long, but it's really based upon the evidence that is generated over time for us to be able to do that. I do want to say that we have some questions have been raised as it relates to this D19RM applications over the last couple of weeks with regards to antigen-based testing. So we did issue an infographic, which we sent to all of our WRs, and it will be posted on the website, just to clarify the appropriate use of antigen-based tests. Antigen-based tests with a minimum level of performance, they have to have certain standards, are easy to use. They can be used outside of laboratory and clinical settings by trained individuals, as you heard Dr. Briand say, and we have issued the training itself. These can be done in communities, and we need the testing to be linked to public health action. What we've done in our information graphic is we tried to articulate even more clearly where these tests can be used. They can be used for case finding. So any suspected cases of SARS-CoV-2 you can use an antigen-based test. They could be used for contact tracing. As you know, contact tracing is really critical to be able to break chains of transmission. And in particular, we also say that they can be used to test asymptomatic contacts, especially those who are at a higher risk of infection, a higher risk of exposure, and a higher risk of developing severe disease. Antigen-based tests can be used for outbreak investigations where you have clusters of cases, and especially in situations where PCR systems are overburdened. And antigen-based tests can be used to monitor trends. So there are many, many different settings in which antigen-based tests can be used. So we've outlined those already. And that's actually based on the September 2020 guidance that's out. We're working in the update to provide some new algorithms to support those who are developing the policies and to outline considerations, because there are differences between guidance and policy. And so what we want to do is be able to support countries in the use of any tests, reliable tests that are EUL tests, linking to public health actions, and to give the right considerations to those decision makers to choose which are the best tests to be used in the situations in your countries based on the risks, based on the intensity of spread. So we will continue to do that, and we thank you for your support and for all of the public health, medical, and scientific professionals who are helping us in generating that guidance. Thank you.
Thank you very much, Maria. Also, just for me to respond or initiate the response to New Zealand, for the networks and the webinars. So the WHO goes through its regional networks, the laboratory networks, and in advertising for some of these events, and the joint ones between WHO and FIND that also have been initiated. We work with FIND on developing the announcements and distributing them to the widest networks through all of our networks as much as possible. And Emma, I'll give her the floor in a minute to add a little bit to that, just in case she wants to bring attention to the announcements issues. With regards to the utilization, again, of our guidance and incorporating them for policy implementation at the country level. And as you've seen, one issue that is very critical when it comes to the antigen RDT was the pricing issue, and it continued to be at a high level for quite a while. And we're hoping that through the ACTA accelerator and our partnership there, that we can even further push the price down, because countries become reluctant to actually use antigen RDTs that need to be used frequently and repeatedly, because it's not a one-time thing. And I hope that if we're capable of bringing those prices down, even below what Emma had shown, I think there was great progress, but the prices do need to come down more. I'll hand it over to Emma if she has any further comments on that. Go ahead, please.
Many thanks, Nan. And just briefly on the country roundtables, they're an excellent opportunity for us as ACTA to share our plans, refine them with countries, and make sure there's a connection through to the countries to be able to know, particularly as new ideas, new areas emerge very quickly in the diagnostic space. As Hanana says, we use the laboratory networks via WHO, the CCM networks via the Global Fund for invites. We're also happy for others to join, and so I'll drop into the chat the email address if we have for some reason missed your technical teams in country. So please feel free to email us, and we'll certainly add you to those lists. At the moment, we're looking at having the next upcoming meetings in the Southeast Asian region and in the Africa region, and also have periodic more global sessions as well. I also just wanted to pick up very briefly on the thread from our colleague from Zambia, who talked about the particular need for testing, especially as cases are starting to rise, and how quickly countries can exhaust their supply of diagnostic testing. Again, why it's so critical that requests for diagnostic testing via the fast-track mechanism and C19 come in. He also pointed to the issue of quality of diagnostic testing, and we know that low quality testing is a significant issue, particularly for potential damage that it can do to good clinical care for the patients who present to get the tests, but also for undermining public confidence in the tests and the test results. And so having quality assurance systems to ensure that the tests that are used in country meet the minimum performance threshold reliably is especially important, including the WHO emergency use listing, which is one of those systems, as well as country regulatory authorities.
Wonderful. Thank you, Emma, very much.
For all those questions and comments, and thank you to today's presenters. I understand there's another member state who would like to take the floor. France, I understand France would like to take the floor. Over to you, France.
Oui, merci beaucoup, Tim. Et comme on a un petit quart d'heure, je pensais en profiter pour poser d'autres questions. Comme on l'a entendu dans les différentes présentations, l'utilisation des tests n'est pas qu'une question d'argent. Il faut aussi pouvoir compter sur les chaînes d'approvisionnement et la possibilité pour les pays de mettre en œuvre une stratégie de tests. Donc à ce titre, on veut souligner l'importance du connecteur sur le renforcement des systèmes de santé et les activités.
Emphasize strengthening the healthcare system, communication efforts, and so forth. And thanks for providing the guidelines that have been published by WHO and partners. I think we also need a more national touch on the implementation and the techniques that can be provided to countries so that we can address the concrete impact that these can have on the ground when it comes to strengthening country capacity. Rapid reaction or rapid texts can be deployed in specific contexts. That is very good news. However, we also think that it's very important to really focus on strengthening lab capacity and lab know-how, which can be turned to surveillance on other diseases. Another question regarding the tests, regarding the OUL procedure. Do we have quite simply too little information, too little files, data, or is it a matter of quality of the data? Is it also related to maybe what could be done at a local scale? Could this become a problem down the road, or can we survive with 4 or 5 antigen tests that can be produced throughout the world, or are you concerned with barriers to access in this regard and IP matters? The last issue I want to raise that was also mentioned by the head of FIND, there's the issue of the quality of tests. Do you have a map of countries where you might have false tests in circulation, or where this quality issue becomes a challenge and therefore this puts in jeopardy the quality of surveillance? I have 2 other issues that are not included on today's agenda, but I hope that you'll be able to address. The first has to do with vaccinations. Could you tell us if WHO is working on a pre-qualification of vaccines that have already had an OUL, or is this not going to be useful? Regarding the 70% coverage that was mentioned by the DG, I'd like to know if this is underpinned by scientific premises. Last but not least, I want to repeat the request that was made by the European Union regarding follow-up on the studies that looked at the origin of the virus. We'd like to have further exchanges with the Secretariat and other international players so that the phase 2 work can be presented to member states, obviously in an unpoliticized atmosphere and with strict adherence to scientific principles. Thank you very much.
Thank you very much, Bernard, from France, for those questions. Just in relationship to the questions on the regulatory issues, we will take that on notice, and someone will come back to you on that. We don't have the relevant staff in the room today, but we have noticed that question and shall revert. In terms of the first question that was raised, I'll give the floor to Maria, please. Maria van Kerkhove.
Thank you. So fully agree with your comments about the national touch, as you phrased it, and building capacities and making sure that we build capacities not only for this virus, but for all infectious pathogens and hazards in the future. And as you know, as WHO, we've been working to do this with you, with partners, for many, many years, and building on existing platforms like we have for the global influenza surveillance and response network, and we have for other disease-specific lab networks as well as surveillance networks. But how we build this, we use this moment, this energy, this emphasis right now to strengthen those systems in country, and we build something more sustainable for the future. So making sure that those capacities exist, that they're sustainable, and that know-how remains and persists. And so fully agree with you on that. With regard, I don't know if DG wants to touch upon the origins, but with regards to this, you've heard us speak before. We very much look forward to the phase 2 studies, and we're working to put together proposals for this, and we will continue to discuss with member states, and this will be done in a scientific and a transparent way. And we're very much looking forward to further exchanges with member states, with the scientific community on the collaborative further studies that need to be conducted to better understand the origins of the SARS-CoV-2 virus.
Thank you very much, Maria. I actually understand that we do have Chief Scientist, Dr. Swaminathan, online, and I did now invite Sumya, please, to intervene on Francis' question.
Yes, thank you very much, Tim, and thanks for that question. I think there were 2 questions from France that are very important. The first one was about the pre-qualification of the vaccines that are under emergency use listing, and the other one was about the 70% target. So on the first one, pre-qualification, as you know, we are in a very unusual situation. Currently, we are using a lot of vaccines under emergency use listing, and I think this is the first time that WHO and, of course, many other regulatory agencies have done this at such scale And obviously, we've had now 2.4 billion doses of these vaccines administered worldwide. So the evidence is accumulating very rapidly on efficacy and safety. When WHO put out the EUL requirements last year, it was meant for a period of 1 year. And therefore, the first vaccine that received an EUL was on the 31st of December of 2020. So at the time, around the time that these vaccines will complete 1 year of EUL or before that, there is an opportunity for the manufacturers to have a discussion about moving from EUL to a full licensure with enough adequate data that needs to be provided. So at this point of time, we do not have a policy guidance on this and how it's going to happen and play out, but we have started discussing. And I'm speaking on behalf of my colleague, Dr. Simao, and her team in the PQ and regulatory unit, because we discussed this recently. And we will update you on the processes that could be followed actually to move from an EUL to a full licensure. On the question of the coverage that's going to be needed to achieve the goal of a full control or further goals of elimination, etc., we do need to do some more homework. There is a lot of work going on, and I think Dr. Kate O'Brien last Thursday presented the data, the work that's going on in developing the strategy, the COVID vaccine strategy. And that strategy actually looks at these kinds of questions as to what percentage of the population would need to be covered. What's the best approach to vaccination in terms of getting a quick public health control of the disease? What about children? And this information is evolving, the knowledge base is evolving because we are getting more and more information from vaccine usage through the vaccine effectiveness studies on what impact it's actually having at the population level, both in terms of disease control as well as in terms of the control of onward transmission. And of course, to add to all this is the role that the new variants are playing, and some of the variants we've seen are less able to be contained through the immune response to these vaccines. Even though they all work very well against severe disease, they may not be as effective against prevention of the infection. And so as this data comes in and it's being fed into the models, it is a dynamic situation. So we know that we will need to aim for at least 70% in order to bring this under control. We just know that from the properties of the virus. But it could be higher than that, and it could be lower than that in order to achieve a state where there's enough control for economies to open up. So again, we will come back to you in about 2 weeks with the advanced version of the strategy, which will lay out these different options for countries, because we recognize how important it is for planning and decision making. Thank you.
Thank you very much, Sumya. I'd now like to hand the floor to Dr. Emma Hannay from FIND. The floor is yours.
Many thanks. There were some really excellent points that were raised earlier by France, and just to touch on a couple of those. One of them was around the importance of laboratory strengthening, building into the medium to long term. And I think this applies both for the COVID response, how COVID interacts into health systems. So how does it link through to better tuberculosis programs, perhaps to more effective diagnostic testing available for a range of other diseases and for future health threats as well. One area within ACTA-DX where that is particularly top of mind is in the genomic surveillance working group that Sylvie spoke about, where building a system focused on respiratory surveillance is really top of mind, not just for the immediate COVID response, but something that looks forward as well. In terms of the tests that are available, particularly the rapid tests, the question came up, is the 4 tests that are currently available under EUL as sufficient. There is a pipeline of promising tests, and Hanan touched on the number that are currently undergoing evaluation. But certainly in those 4 tests, there is significant manufacturing capacity that is available. So at the moment, as a few of the speakers have alluded to, there is a significant supply, and so actually some of the focus within ACTA is really on how do we create the appropriate demand from countries to be able to support their response. It's probably one of the more significant focuses than getting more and more products through the EUL process. The question on the quality of tests was a really good one. And there's typically very little data that's available on all of the tests that are used in countries. And this does vary, but there's not always a lot of regulation that prohibits the use of low quality tests in countries, which can mean it's very hard to get a perspective on exactly what's used in countries outside the public health system. And so I think that's an area where perhaps there's some lessons that can come out of that for us all, looking forward to this future diagnostics ecosystem that we'll create after COVID.
Thank you very much, Emma. I'd now like to invite Mr. Peter Sands for any final comments that you may wish to make.
Thanks, Jim. Very briefly, first, on Francis' points about the country perspective and also the importance of systems, I agree entirely with both, and indeed the way C19RM is designed is that it's for the countries to prioritise what interventions they want funded across the range of therapeutics, diagnostics, health systems, and so on. At the moment, the data is oriented towards the commodities simply because the fast track procedure was for commodities. As we get more of the full funding submissions awarded, you'll see more systems interventions being funded. To the discussion on sort of policy and guidance, I just think we have to accept, and it's very consistent with what Sumya was saying in the context of vaccines, this is a very dynamic situation. The epidemic itself, the pandemic itself is evolving, the technologies are evolving, and we're learning fast. And that's why I very much appreciate, as Maria said, the most recent clarifications through the infographics, extremely helpful, and look forward to the revised guidance. Just on the point that Emma just made about the number of antigens available, there isn't a manufacturing constraint relative to demand right now. However, if we got the demand we ought to be getting, there would be. And we do need the more antigen IDTs receiving EUL approval, not least because, frankly, that's the most powerful way we're going to get price pressure. And then just lastly, a very specific point for Zambia. Zambia had 43.5 million approved under the fast track procedure. If you'd like, I'm sure we can offline provide you with the details of that approval. Thank you.
Thank you very much, Peter. And I understand Dr. Bruce Al would like to make a very brief intervention before I hand the floor to the DG for closing remarks. Bruce, are you still with us?
Yes, indeed, Tim. And it was just briefly to the question about the 70% coverage. Indeed, that is based on the best possible evidence so far as to what is needed in terms of population coverage with vaccines to suppress transmission of the virus. Clearly, there may be a resumption of social economic activity at lower coverage levels, but to the question of the levels of coverage to suppress transmission, emerging scientific evidence says it's a combination of modeling and other inputs suggests that level. We will be coming back in 2 weeks after SAGE has considered the draft of vaccines strategy update to provide further information on that. But a crucial point, we want to make sure there's clarity on.
Thank you very much, Bruce. And as we are just a few moments over the 2 o'clock end date, it's now my pleasure to give the DG the floor for your final comments. Over to you, DG. Thank you.
Yeah, thank you. Thank you, Tim. I think nothing to add except thanking all member states for joining today's weekly mission briefing. And my appreciation also to Peter Sams and Emma for joining us. And all the best. Thank you. Back to you.
Thank you very much, DG. Thank you to all today's presenters, and of course a very warm thank you to our member states for your active participation. Have a very good afternoon, evening, night, or very early morning, depending where you are in the world. Thank you.
Very much. With that,
And all the best. Thank you. Back to you.
Just a few moments over the 2 o'clock end date. It's now my pleasure to give the DG the floor for your final comments. Over to you, DG. Thank you.
Yeah, thank you. Thank you, Tim. I think nothing to add except thanking all member states for joining today's weekly mission briefing. And my appreciation also to Peter Sams and Emma for joining us. And all the best. Thank you. Back to you.
Thank you very much, DG. Thank you to all today's presenters, and of course a very warm thank you to our member states for your active participation. Have a very good afternoon, evening, night, or very early morning, depending where you are in the world. Thank you.